Think about the incredible leaps medicine has made. It's amazing, really. We can now navigate and repair the body's intricate pathways, like, blood vessels, often just through a tiny entry point.
Minimizing the need for big open surgeries. It's truly remarkable progress.
It really is.
And these procedures, these minimally invasive endovascular interventions, the ones that treat vascular disease, well, they depend entirely on being able to see inside the body without cutting it open.
Right, you need eyes inside.
Exactly. And that relies on an invisible force, X-rays, ionizing radiation.
Okay, so this invisible tool is absolutely essential for success, guiding catheters, placing stents, making sure everything lands exactly where it needs to.
Couldn't do it otherwise, not like this.
But we all know radiation isn't something to take lightly. It comes with potential risks if not handled with, well, extreme care.
That's the crux of it. Balancing that necessity with safety is just paramount. And that's precisely what we're diving into today.
Welcome to the Deep Dive, your way to cut through the noise and get informed on complex topics. Today, we're peeling back the layers on recent authoritative clinical practice guidelines.
These are from leading experts like the European Society for Vascular Surgery.
And they focus squarely on radiation safety during these specific blood vessel procedures.
Yeah, our goal here is really to make sense of these recommendations for you.
Whether you might be a patient, maybe preparing for one of these interventions, or perhaps a caregiver supporting someone who is.
Or even if you're just someone curious about medical technology and, how safety keeps pace with innovation.
We'll explore why radiation is used, what the potential risks actually are, and most importantly, the specific practical strategies medical teams are using to keep radiation exposure for everyone involved, especially you, the patient, as low as reasonably achievable.
That ALARA principle, it's key.
Let's unpack this challenge.
Okay, so let's start with the procedures themselves. Endovascular procedures, they're used for diagnosing and treating vascular disease problems with arteries and veins.
Instead of those large incisions we mentioned.
Exactly. Tiny cuts are made, maybe just a few stitches, and specialized instruments like catheters and wires are threaded through the blood vessels to the area that needs attention.
And you need that constant visual guidance inside the body to know where you are, what you're doing.
Precisely. That's where the X-ray imaging comes in, specifically something called fluoroscopy.
Fluoroscopy. That's like the live video X-ray.
Exactly. It's the team's real-time eyes inside the patient's anatomy. And even before the procedure, diagnostic steps like a CT angiography scan, which also uses X-rays, help map out the blood vessels and the problem area.
So radiation is really a fundamental part of this whole approach. You can't avoid it.
It is. These procedures wouldn't be possible, or certainly wouldn't be as effective or minimally invasive without it. But, as we said, this exposure carries potential health consequences. Understanding those is really the first step in appreciating all the safety measures.
Okay, let's talk about those potential health effects. The guidelines categorize them into two main types. Can you walk us through those?
Absolutely. The first type are called deterministic effects. You might also hear them called tissue reactions.
Deterministic. Okay, that sounds like if you get a certain amount of dose, something specific will happen. Is that right?
That's the core idea, yeah. For these effects, there's what we call a threshold dose.
A minimum level.
Exactly. Think of it like a minimum level of radiation energy that needs to be absorbed in a specific tissue or organ before any damage occurs. And here's the critical part. If the dose goes above that threshold, the severity of the harm increases as the dose gets higher.
So hit the threshold, you might see an effect, go way over it. The effect gets much worse. A burn getting worse with more heat.
That's a good analogy. The guidelines highlight examples like skin damage. This can range from temporary redness, like a sunburn, to, at very high doses, more serious issues like blistering or even ulceration where the X-ray beam enters the body.
Okay.
Another key example is damage to the lens of the eye, which can lead to cataracts developing over time.
And how do medical teams assess the risk of these deterministic effects for a patient during a procedure?
Well, the most relevant measure here is called the peak skin dose, or PSD. It's measured in a unit called gray.
Peak skin dose. So the highest dose to any one spot on the skin.
Exactly. It represents the highest dose of radiation absorbed by any single area of the patient's skin. Now, procedures that are long or complex, the ones requiring extensive fluoroscopy time and lots of X-ray images, they're more likely to result in a high peak skin dose.
Makes sense. More radiation time, higher peak dose potential.
Right. And the guidelines actually note that reaching certain dose thresholds, like a peak skin dose over 3 gray, Or another measure called air kerma at the patient reference point over 5 gray, these can be considered unintended medical exposures.
Meaning they trigger specific actions?
Yes, they require specific follow-up with the patient afterwards to check for any skin reactions or other issues.
Okay, so they're actively monitoring for these high-dose situations where tissue reactions become a real possibility. What's the other type of effect? Stochastic, you said.
Stochastic effects, yes. These are quite different. They're all about probability, not severity linked to a threshold dose.
Probability. So chance.
Exactly. These effects happen by chance, and the likelihood, or the probability of them occurring, increases with increasing radiation dose. But, and this is important, if one does occur, its severity isn't necessarily tied to how high the dose was.
Okay, so the chance goes up with dose, but the outcome, if it happens, is sort of random in its severity.
That's a way to think about it. And the model used for radiation protection, it's called the linear no-threshold model, or LNT. Well, it basically assumes there is no safe threshold dose for these stochastic effects.
No safe threshold. So even tiny doses carry some risk.
Theoretically, yes. The model suggests that even very low doses could carry a very, very small probability of causing harm. Now, the evidence for actual harm at very low doses is debated, but for safety planning.
I assume any exposure carries some tiny chance.
Yeah. That's the conservative principle used for radiation protection purposes, yes. And the most significant stochastic effect the guidelines discuss is the increased risk of developing cancer later in life.
Right, cancer risk. How is that risk estimated or measured?
That's estimated using a unit called the effective dose, and it's measured in Sieverts.
Sieverts? Okay.
The effective dose is clever. It takes into account the total amount of radiation energy absorbed, like the gray unit does, but it also factors in which specific organs were exposed and how sensitive those particular organs are to radiation.
Ah, so it weights the dose depending on where it hits.
Exactly. Organs like the bone marrow, the colon, lungs, stomach, breast tissue, they're considered more radiosensitive. So dose to those areas contributes more to the overall effective dose calculation.
I see. And for the x-rays used in these procedures, how do Gray and Sievert relate?
For X-rays, it's numerically quite simple. 1 sievert of effective dose is essentially equal to 1 gray of absorbed dose delivered uniformly to the whole body. But the Sievert unit is really designed to help compare risks across different types of radiation, not just X-rays.
Got it. So effective dose gives a picture of the overall body-wide stochastic risk, considering which parts got exposed. And I imagine age plays a big role here too.
It's a huge factor, and the guidelines really emphasize this. Younger patients are at a greater lifetime risk from stochastic effects.
Because there's more life left for something to potentially develop.
Precisely. The potential consequences, like a radiation-induced cancer, often take many years, sometimes decades, to develop after the exposure. A younger person simply has more years ahead of them for that possibility to manifest.
That makes intuitive sense. More time for that dice roll, as you said, to potentially land on an unfavorable number. The guidelines give a pretty stark example of this, don't they?
They do. They point out that the estimated lifetime risk of developing cancer from, say, a CT scan of the heart arteries is significantly higher for a 20-year-old woman compared to an 80-year-old woman undergoing the exact same scan.
Wow. Same scan. Vastly different lifetime risk just based on age.
It's purely due to the difference in remaining lifespan and the time available for those stochastic effects to potentially emerge.
That really underscores why minimizing dose, especially in younger patients or patients needing repeated procedures over time, is so incredibly important.
Absolutely.
You mentioned some studies looking at cancer risk after specific procedures like endovascular aortic repair or EVR.
Yes, there has been some research suggesting a possible weak link between EVR and perhaps a slightly increased risk of certain abdominal cancers down the line compared to traditional open surgery. However,
It's not clear cut.
no, the guidelines are very careful to state that the current evidence isn't conclusive. These studies often weren't specifically designed to track cancer outcomes long term, and there are many other factors, confounding variables, that could explain the findings. We really need more dedicated long-term research on that specific question.
Okay, so a potential signal, but needs more investigation. Now, going back to the deterministic effects for a moment, you mentioned cataracts, but you also said the understanding of that risk has actually changed quite significantly.
Yes, this is a major update in the radiation safety field, particularly relevant for the medical staff. Radiation-induced cataracts were previously thought to be strictly deterministic, requiring very high doses, above maybe 0.5 gray before they would occur.
A high threshold.
A high threshold, yes. But newer evidence strongly suggests that lens opacities, which are basically early signs of cataracts, can actually occur at much lower cumulative doses, perhaps below 2 gray, maybe even below 0.5 gray, absorbed by the lens.
That's a huge drop.
It is, and this raises the worrying possibility that there might be no safe threshold dose for this effect, meaning that cumulative low doses over a career really matter.
More like a stochastic effect then.
Yeah.
Or somewhere in between.
The classification is still debated, but the practical implication is clear. Cumulative dose matters much more than we thought. And this is why eye protection for medical staff is now considered so essential. Studies show that interventionists, the doctors performing these procedures regularly, have a significantly higher reported rate of cataracts compared to the general population or other medical staff not exposed to radiation.
Wow, that's a fundamental shift in understanding a key risk, especially for the medical team. Okay, so we know the types of risks. How do the teams actually track and measure the radiation being delivered during a procedure? What numbers are they watching?
They use specific measurements that are recorded by the X-ray equipment itself, the CR machine. As we touched on, the unit gray measures the absorbed dose, the amount of energy deposited in body tissue.
And Sievert estimates the biological risk, the effective dose.
Right, accounting for tissue sensitivity, allowing for that stochastic risk estimation. But during the procedure itself, the machine gives them more direct, real-time feedback on the radiation output.
What are those key parameters?
One is called Kerma area product, or KAP. You might also hear it called dose area product, or DAP.
AAP.
It measures the total energy output of the X-ray beam across its entire area. You can think of it as the total radiation energy burden being delivered by the machine. The guidelines note that air Kerma area product, or PKA, is the newer, more technically accurate term they recommend using.
Okay, so KPP or PKA is the total energy output. What else?
Another key one is cumulative air Kerma, or KAK. This measures the total dose delivered to a standardized reference point in the air, usually near where the patient's skin is positioned relative to the X-ray tube. It gives an idea of the dose concentration at the entry point.
So KPPKA is the total energy blast, and KK is more about the intensity at the skin entrance point.
That's a good way to put it. And these measures, KAP and KAK, are considered much better, more objective indicators of the actual radiation exposure than simply tracking fluoroscopy time.
The fluoroscopy time being just how long the live X-ray video were running.
Exactly. And why are KPA and KAK better? Because fluoroscopy time alone doesn't tell you anything about crucial factors like how high the X-ray power settings were, or how large the beam area was, the collimation, or the angle of the machine.
Ah, right. You could have the beam on for a long time at very low power or a short time at very high power.
Precisely. A long fluoroscopy time with low settings and tight collimation might actually result in less total dose than a short fluoroscopy time, using high power settings and a wide open beam. KAK, K, and SCIP give the team a much more accurate picture of the actual radiation delivered to the patient.
That makes perfect sense. It's not just how long the light was on, but how bright it was and how wide the beam spread.
You got it. And the guidelines emphasize, in fact, it's a Class 1 level law recommendation, meaning it's legally required in many places that modern X-ray machines must provide detailed dose reports.
Including these KAP and KAK values.
Yes, often displaying cumulative KAP and KAK values in real time during the procedure.
Wow.
This immediate feedback is essential for the team to monitor the exposure as the procedure progresses and make adjustments if needed.
Knowing they're monitoring that data live is definitely reassuring. Okay, let's shift focus now to what matters most to the patient and their family. Actively reducing that exposure. What do these guidelines say about protecting the patient?
Well, the absolute starting point, and this is another Class 1 level law recommendation, is information. Patients must receive clear, plain language, easy to understand information about the potential radiation risks before the procedure takes place.
As part of the consent process.
Exactly. It should be a key part of the informed consent discussion. This might involve verbal explanation, written materials, or both. It's fundamentally about explaining why radiation is necessary for this specific procedure for this specific patient, and carefully balancing the expected benefits of the intervention against its potential risks, including radiation.
So informed consent absolutely has to include understanding the radiation component.
Without question. And the core principles guiding the medical use of radiation for patients are, firstly, justification, making sure the procedure's benefits clearly outweigh the radiation risks for the individual patient, and secondly, optimization.
Which brings us back to ALARA.
Exactly. Optimization is the ALARA principle in action, keeping doses as low as reasonably achievable while still getting the diagnostic information or therapeutic effect needed. It's crucial to remember that the strict dose limits that apply to occupational exposure for staff or to the general public, those don't apply to patients undergoing necessary medical procedures.
Because the dose needs to be whatever is required for that specific medical task.
Right. The necessary dose depends entirely on the individual's clinical situation, guided always by justification and optimization by ALARA.
Okay, ALARA is the guiding star. What are the specific practical ways the medical team actively works to keep patient doses low during the procedure itself?
The guidelines list quite a few key strategies. One is simply minimizing pedal time.
The time their foot is actually on the pedal, activating the X-ray beam.
Exactly. Operators are trained to use short, pulsed bursts of fluoroscopy, sometimes called spot fluoroscopy, rather than keeping the beam on continuously. They also make heavy use of features like last image hold.
Which freezes the image.
Right. It's mandatory on modern systems. It freezes the last live image on the screen so the team can study it, discuss it, plan the next step, all without any continuous radiation exposure. They also review previously recorded loops or short video clips of the imaging instead of repeating live runs.
So they're not just running the video the whole time. They're strategically using still frames and short recorded clips whenever possible.
That's the goal. Another major strategy, and this is a big one for dose saving, is significantly reducing the use of digital subtraction angiography, or DSA.
DSA. That's one that gives those really sharp images, just the blood vessels, right? By subtracting out bone and tissue.
Exactly. It provides excellent image quality, but it comes at a cost. DSA uses substantially higher radiation doses than standard fluoroscopy. We're talking maybe up to 10 times higher dose rate per frame.
10 times higher.
Yeah. The guidelines note that DSA can sometimes account for anywhere from 50% up to even 90% of the total radiation dose delivered during an entire procedure.
That's a staggering proportion. So limiting DSA is absolutely critical for patient safety then.
Absolutely critical. Teams are trained to reserve DSA for only the most essential steps where that high image quality is truly needed, like deploying a stent precisely. For navigation and general visualization, they should use lower dose alternatives like standard fluoroscopy loops or specialized roadmap features whenever possible.
Roadmap features, like an overlay.
Sort of, yeah. It superimposes a previously captured DSA image faintly onto the live fluoroscopy screen as a guide. And when they do use DSA or even fluoroscopy, they should always use the lowest image quality setting, which usually means the lowest frame rate, like fewer images per second that is still clinically effective and safe for the task at hand.
Okay, so less DSA, lowest effective frame rate. What else? Does shaping the beam help? Collimation.
Yes, collimation is very important. It's essentially using adjustable shutters, usually lead shutters, built into the X-ray machine to narrow the beam down, restricting it to only the specific anatomical area they need to see at that moment.
So it reduces the total amount of tissue being irradiated.
Exactly. This significantly reduces the overall dose to the patient, and as a major bonus, it dramatically reduces the amount of scatter radiation produced, which is great for staff safety. However,
There's a catch.
there's a nuance. While collimating reduces the total dose, it does concentrate the dose on that smaller area of the patient's skin that remains in the beam. So the guidelines caution against prolonged use of very tight collimation focused on one exact spot for too long, as that could increase the peak skin dose in that specific area. It's a physics principle they need to keep in mind.
Okay, so narrow the beam to what's needed, but maybe shift the center point slightly now and then if you're imaging the same general area for a long time.
That's the idea. Patient positioning is also key for dose reduction.
How so?
The guidelines strongly recommend positioning the patient as close as possible to the X-ray detector, which is usually part of the C-arm called the image intensifier or flat panel detector. This is a Class 1, Level B recommendation based on physics.
Closer to the detector means less dose needed.
Significantly less, yes. The closer the patient is to the detector, the less radiation the machine needs to output to get a clear image. It also generally reduces magnification distortion.
Makes sense. What about the angles the X-ray machine itself is positioned at? Does that matter?
It matters quite a bit, actually. Using very steep angles with the X-ray machine, particularly for prolonged periods, is generally not recommended. That's a Class 3 Level B recommendation, again, based on a physics principle.
Why are steep angles bad for dose?
Because when the C-arm is angled steeply, the X-ray beam has to pass through a much greater thickness of the patient's body tissue to reach the detector on the other side. To get through all that tissue and still make a good image, the machine automatically increases the radiation output, sometimes substantially.
So it has to blast harder to get through more stuff.
Exactly. This significantly raises the patient's skin dose, especially at the beam entry point, and it also increases the amount of scatter radiation bouncing off towards the staff. So keeping the C-arm angles as close to vertical or horizontal as possible whenever the view allows is generally better for everyone's dose.
Okay, flatter angles are better when practical. It sounds like technology plays a huge role in helping with all this, too.
Oh, absolutely. Modern equipment has numerous built-in dose-saving features and software enhancements. For instance, preoperative planning software.
We mentioned that earlier for mapping things out.
Right. Using detailed 3D images from a prior CT or MRI scan, the team can plan the procedure virtually on a computer workstation. They can figure out the best, safest C-arm angles to use before the patient is even on the table. This reduces the need for extra scout X-ray runs during the actual procedure just to find the right view. That's a Class 1, Level C recommendation.
So doing homework on the computer saves radiation time in the operating room.
Precisely. And then there's technology like 3D image fusion software.
Fusion, blending images together.
Exactly. This software can take those pre-procedure 3D CT images and overlay them, accurately registered, onto the live 2D fluoroscopy screen during the case. It acts like a sophisticated dynamic roadmap.
Like GPS for blood vessels.
That's a great way to think of it. It helps guide the catheters and wires, potentially reducing the need for frequent contrast injections to visualize the vessels, and often reducing the need for those high-dose DSA runs. So it can lower both radiation dose and contrast dose. That's rated Class 2A, Level B recommendation. Good evidence suggests it's beneficial.
That sounds incredibly useful.
Yeah.
Any other tech tricks?
Yes. Using digital zoom instead of traditional geometric magnification is another recommendation. Class 1, Level C. Digital zoom just electronically enlarges a part of the already captured image on the monitor. It doesn't require increasing the radiation dose. Older methods of magnification actually involve moving the patient further from the detector, which did increase the dose.
So use the software zoom, not the physical zoom. It sounds like technology is a really powerful ally in this fight for lower doses.
It truly is. And underlying all of this, something fundamental but crucial: regular maintenance and quality control testing of the X-ray equipment itself.
Keeping the machine in tune.
Exactly. This is actually a legal requirement in most places, a Class 1 level law recommendation. Ensuring the machine is properly calibrated and functioning optimally is essential for producing the best possible image quality at the minimum necessary radiation dose. A well-maintained machine is inherently a safer machine.
Okay, so a huge amount goes into protecting the patient. But the medical team, the doctors, nurses, techs, they're right there in the room, often for hours. How do they protect themselves from this radiation?
That's equally critical, and the guidelines dedicate a lot of attention to it. The primary source of radiation exposure for the staff isn't the direct X-ray beam itself, they should never be in that, but rather the scatter radiation.
The radiation that bounces off the patient's body.
Precisely. When the primary beam hits the patient, X-rays scatter in all directions, sort of like light reflecting off a surface, and the scatter radiation fills the room. This is where a fundamental physics principle becomes incredibly important for staff safety: the inverse square law.
The inverse square law. Okay, break that down simply for us. How did that help?
It's actually quite intuitive and incredibly powerful. It states that the intensity of radiation decreases dramatically specifically with the square of the distance as you get further away from the source.
Okay, so double the distance.
If you double your distance from the patient, who is the source of the scatter, the amount of scatter radiation you receive drops to just 1/4 of what it was.
A quarter. Just by doubling the distance.
Exactly. And if you triple your distance, the exposure drops all the way down to 1/9. Distance is your best friend when it comes to radiation protection.
Wow. That's a huge difference just by taking literally a step or two back.
It is. And applying this principle, simply stepping back away from the patient table whenever possible, especially during moments known to produce high scatter like those DSA runs we talked about, is one of the simplest, cheapest, yet most effective safety measures staff can take.
So if they don't need to be right next to the patient for a moment, they should consciously move away.
Absolutely. Sometimes, for very high-dose acquisitions, staff might even momentarily step behind a lead shield or even just outside the door if their presence isn't immediately required.
Literally putting distance and maybe shielding between themselves and the source. What about their position around the patient table when they do need to be close? Does that matter?
Yes, the distribution of scatter isn't uniform around the table. The guidelines note that the highest levels of scatter radiation are typically found on the side of the patient where the X-ray tube is located, where the beam enters the patient. The exact location varies depending on the C-arm's angle, of course.
So the team needs to be aware of those potential hotspots.
They do. The operators and assistants standing closest usually get the highest doses, but personnel positioned at the head end of the table, like anesthesiologists or nurse anesthetists, can also receive significant scatter exposure, particularly to their head and neck area. Everyone in the room needs to be mindful.
It's not just the person holding the catheter. Okay, so distance and positioning are key behavioral strategies. What about the gear they wear? The personal protective equipment, or PPE? We always see those lead aprons in pictures.
Yes, the lead apron is the cornerstone of personal shielding. Think of them as the shielding superheroes of the suite. They work very well, typically reducing the dose reaching the torso by over 90%.
It's a huge reduction.
It is. The guidelines recommend that everyone working in the radiation field should always wear a properly fitted lead apron, and it should have at least 0.35 millimeters of lead equivalence. That's a Class 1, Level B recommendation based on that physics principle of attenuation. Wraparound-style aprons offer more comprehensive protection, covering the back as well.
And they need to fit well.
Fit is important. Too loose and radiation can scatter underneath, too tight or heavy, and it can cause orthopedic strain over time. Some guidelines also mention considering axillary supplements, extra flaps under the arms, particularly for female operators, to provide better breast protection, Class 2A recommendation.
Okay, aprons are essential. What about protecting the neck, the thyroid gland?
Absolutely crucial. A thyroid collar or shield is always recommended, Class 1, Level C. The thyroid gland is known to be quite sensitive to radiation.
And lead glasses, especially now with that updated understanding of cataract risk at lower doses.
Yes, this is a critical point emphasized in the guidelines. It's recommended that operators and anyone else routinely close to the beam should always wear appropriately fitted leaded eyewear. These typically have around 0.75 millimeters of lead equivalence in the front, and often side shields too. Protecting the eyes from that cumulative low-dose exposure over a career is now considered paramount. That's a Class 1, Level C recommendation.
Okay, aprons, thyroid collars, lead glasses check. What about protecting the hands? Do they wear lead gloves?
This is interesting and perhaps counterintuitive. Radiation protective gloves are generally not recommended for routine use by the operator. That's a Class 3 recommendation, meaning it's advised against.
Really? Why not? Don't hands get close to the beam?
They can, but the problem is twofold. First, lead gloves offer fairly limited protection for the amount of dexterity they sacrifice. Second, and more importantly, wearing them might give a false sense of security, potentially encouraging operators to place their hands closer to or even in the primary X-ray beam, which should never happen.
Ah, so the best practice is just keep your hands out of the beam entirely.
Exactly. Keep hands out of the direct beam at all times. The guidelines explicitly recommend using alternative techniques, like ultrasound guidance for gaining vascular access, like puncturing the artery in the groin or wrist, instead of using fluoroscopy to guide the needle. This is specifically to minimize radiation exposure to the operator's hands. Class 1, Level B recommendation based on physics.
That makes sense. Avoid the beam, don't just try to shield from it minimally. Okay, so no routine gloves. Are there other types of shielding used in the room beyond what people wear?
Yes, several important ones. Table-mounted shields, often called lead skirts or drapes, hang down from the sides of the operating table.
To block scatter coming from below the table level.
Exactly. They're very effective at reducing dose to the legs and lower torso of the staff standing nearby. The guidelines recommend these as a first-line protection measure that should be used at all times. Class 1, Level B recommendation, physics principle.
So always use the table skirts. What else?
There are also suspended personal radiation protection systems. These are more complex setups, often hanging from a ceiling track.
Like the zero-gravity system you sometimes hear about.
That's one well-known example, yes. These systems can provide much more comprehensive whole-body shielding than a standard apron, often including integrated face and head protection. They can significantly reduce the operator's dose, especially to the head, neck, and upper body, compared to traditional PPE. The guidelines suggest they may be considered, particularly in high-volume or high-dose environments where minimizing operator dose is a major priority.
Like a personal radiation force field, almost.
A bit like that, yes. They take the weight off the operator, too, which is a bonus. And another category is radiation protective patient drapes.
Drapes you put on the patient. How does that help the staff?
These are sterile drapes, usually made of lead-free attenuating materials like bismuth or tungsten composites that are placed directly on the patient's body, around the area where the X-ray beam is entering and exiting.
So they absorb the scatter at the source.
Exactly. They work by absorbing a significant portion of the scatter radiation coming off the patient before it can reach the staff members like the operator or the scrub nurse standing nearby. Studies have shown they can be quite effective in reducing staph dose, provided they are positioned carefully so they don't accidentally get into the primary imaging beam, which would obscure the view and potentially increase patient dose.
That seems like a really clever approach, tackling the scatter right where it originates. Okay, so lots of shielding options. How do they actually keep track of the staff's cumulative dose over months and years?
Medical staff who routinely work with radiation are required by regulation to wear personal dosimeters.
Those little badges they clip on.
Usually, yes. They can be badges, often worn on the chest, sometimes under the lead apron, sometimes outside, or even rings worn on the finger. These contain materials that passively record the cumulative radiation dose received over a period, typically 1 to 3 months. They're then sent away to be analyzed, and the results are tracked to ensure individual doses stay well below regulatory limits.
So that provides a long-term record.
It does. While the standard regulatory dosimeter measures overall effective body dose, the guidelines suggest that in high-exposure situations, like busy interventional suites, using additional dosimeters might be considered, Class 2B, Level C. For example, a second dosimeter worn outside the apron at collar level to better estimate eye lens dose, or extremity dosimeters on the fingers or wrists.
To get more specific readings for high-risk areas.
Right. And increasingly, facilities are using real-time active personal dosimeters, or APDs.
These give immediate feedback.
Yes, they often have a small digital display showing the current dose rate and the accumulated dose during the procedure. Some even have audible alarms that beep faster as the dose rate increases. This immediate feedback can be incredibly valuable, allowing staff to instantly see the impact of their actions, like taking a step back or adjusting shielding, and modify their behavior on the spot to reduce their exposure.
So they're not just wearing the gear and hoping for the best. They're actively monitoring and managing their own exposure in many cases, sometimes in real time. This all sounds incredibly complex, requiring constant vigilance and, well, a lot of knowledge.
It absolutely does. And this brings us to a really crucial point highlighted in the guidelines: education and training. They actually point out what they term an alarming knowledge gap regarding radiation protection principles and practices among some medical professionals.
Alarming. That sounds pretty serious. A gap in knowledge.
It suggests that despite all the technology and equipment, ensuring everyone understands how to use it safely and why it's important is still a significant challenge. It highlights the critical, ongoing need for education.
So training is paramount.
Absolutely. The guidelines strongly emphasize that comprehensive radiation safety education and training should be a priority, even mandatory, for all personnel who work in the endovascular suite or any environment where ionizing radiation is used for procedures. That includes physicians, trainees, nurses, technologists, everyone.
Regardless of their role or experience level.
Regardless, everyone plays a role in safety.
And who should be providing this training? What should it cover?
Ideally, it should be delivered by qualified experts, like medical physicists who understand the technical aspects and experienced clinicians who apply these principles daily. The training needs to cover both the theoretical side, the physics of radiation, its biological effects, the regulations, and crucially, practical, hands-on skills in actually using the dose-saving techniques and operating the equipment safely.
Practical training. You mean beyond just lectures, like practicing in a safe environment?
Exactly. The guidelines specifically highlight the value of simulation-based training. This could involve using virtual reality simulators, which are becoming quite sophisticated.
By flight simulators for procedures.
Precisely. Or even physical phantom models with simulated fluoroscopy. These allow staff, especially trainees, to practice performing procedures and, very importantly, see directly how their specific choices, changing the C-arm angle, using magnification versus digital zoom, applying collimation, choosing fluoroscopy versus DSA, immediately impact the estimated radiation dose numbers, all in a completely radiation-free, safe setting.
So they can learn the cause and effect without any real-world risk.
Exactly. And studies have actually shown that this kind of simulation training can significantly improve operators' technical skills and lead to measurable reductions in both radiation dose and contrast medium use when they perform procedures on real patients. It's like practicing landing the plane in the simulator makes you a safer pilot.
That makes perfect sense. Practice makes safer.
It really does. Reflecting this importance, the guidelines state it as a Class 1 level law recommendation that all exposed personnel must complete the appropriate level of radiation protection training required for their role. They also go further, recommending that radiation protection content should be included in national board certification exams for relevant medical specialties. Class 1, consensus recommendation.
Building it right into the qualification process.
Yes, and it's not just a one-and-done thing. Continuous education, refresher courses, and ongoing certification are also often legally required, Class 1 level law. Plus, providing regular, individualized feedback to staff on their personal dosimetry readings is seen as a powerful tool to reinforce good habits and encourage continuous improvement in radiation safety practices.
So it's really embedded as an ongoing process throughout a medical professional's career, not just something you learn once at the beginning.
That's the ideal, yes, a culture of radiation safety.
Looking ahead now, are there new technologies emerging on the horizon that might further reduce the need for X-rays altogether, or perhaps enhance safety even more?
The guidelines do briefly touch on a few promising future developments. One area is robotics.
Robots performing the procedure.
Not necessarily performing it autonomously, but robotic catheter systems that allow the operator to control the instruments precisely from a workstation, potentially located away from the primary radiation field.
So remote control, essentially, putting distance between the operator and the source using technology.
In essence, yes. That could significantly reduce the operator's direct exposure. Another major area with huge potential is artificial intelligence, or AI.
AI. How could AI help with radiation safety specifically?
Well, researchers are exploring several possibilities. AI algorithms could potentially be used to automatically optimize the X-ray imaging parameters in real time during a procedure, ensuring the best image quality at the absolute lowest possible dose.
Machine learning how to be more efficient with radiation.
Sort of, yeah. Or AI could potentially identify the critical anatomical structures and automatically adjust the collimation, the beam shaping, more precisely and dynamically than a human operator might. It might even be possible for AI to analyze the scatter radiation field in the room and provide real-time visual or audible warnings to staff if they move into a particularly high-dose area.
Wow, making the machine smarter about dose reduction and actively coaching the team in real time? That's fascinating potential.
It is, but these are still areas requiring significant further research and development before they become routine clinical practice.
Still early days for AI in this specific application.
Relatively, yes. And it's also important to remember, as the guidelines themselves acknowledge, that while these recommendations represent the current best practices based on expert consensus, much of the supporting evidence for specific interventions is still considered Level C.
Level C, meaning mostly based on expert opinion, case studies, or smaller trials, rather than large randomized controlled trials.
Exactly. This highlights an ongoing need for more high-quality research, larger, well-designed studies to really strengthen the evidence base for many of these radiation protection strategies in the specific context of endovascular procedures. There's also a recognized need for better global harmonization of safety practices and regulations, and for developing better ways to objectively measure the real-world impact and effectiveness of various training programs.
So, even with all this accumulated knowledge and these detailed guidelines, there's still a clear call for more research to solidify the best approaches and ensure everyone is on the same page globally.
Absolutely. Continuous improvement is the goal. These guidelines aren't meant to be set in stone. They are living documents, intended to be updated and refined as our scientific understanding grows and technology continues to advance.
Well, we've certainly taken a deep dive today into the really intricate world of radiation safety during these modern blood vessel procedures. It's become incredibly clear that while ionizing radiation is an absolutely essential tool that enables these life-saving, minimally invasive interventions,
its use is and must be surrounded by a really robust framework of expert guidelines, sophisticated technology, rigorous training, and constant vigilance.
it's a continuous, active effort, all guided by that core principle we keep coming back to, keeping radiation doses as low as reasonably achievable ALARA for everyone involved, patient and staff alike.
That's the commitment.
And hopefully, for you listening, whether you're potentially a patient or a caregiver, understanding that medical teams are armed with this knowledge and these tools, from the requirement to explain risks clearly in plain language before a procedure, to using advanced dose tracking and dose reduction technology in the room, employing sophisticated shielding, and undergoing continuous specialized training, hopefully, knowing all this is in place can offer some real reassurance.
It should also empower you to feel comfortable asking questions about how radiation safety is being specifically managed in your situation or your loved one's situation.
Exactly. And remember, as we just discussed, these guidelines aren't static. They represent a snapshot of current best practices built on decades of research and experience, but they are constantly evolving.
They're the product of continuous learning and adaptation within the medical field.
So perhaps a final thought to leave you with. Consider how this relentless process of refinement in radiation safety, this constant striving for improvement, reflects a really fundamental commitment within medicine. It's about pushing the boundaries of innovation to treat disease more effectively and less invasively, while simultaneously, and just as importantly, pursuing the highest possible standards of safety and care. It's a dynamic balance, always being adjusted, always aiming to get better.